Welcome to Quality. This is your host, Arjun Venkatesh, where we're exploring quality in emergency care. Today's episode is the next in our series from our Substance Use Disorder Initiative of the Emergency Quality Network. And today's a special episode because I'm joined by two wonderful experts, two co-conspirators in this work around the country around improving the quality of emergency care. And not only wonderfully smart people, but also wonderfully nice people who are just going to share, I think, a wealth of knowledge with us today. I've got Dr. Kathryn Hawk from Yale University, as well as Dr. Scott Weiner from Brigham and Women's Hospital. Both co-lead the ASAP E-QUAL Substance Use Disorder Initiative, and were part of the kickoff episode with me. Welcome back, Kate and Scott.
Thank you. Great to be here. I think you left off good looking.
Yes, yes. We need to go video with these podcasts so people can fully appreciate that. I'm really excited to have you guys back because we did a kickoff podcast over a year ago now, almost, where we were really trying to talk about what we'd learned and how we were going to get EDs engaged in doing, treatment for opioid use disorder, to get them really thinking about treatment for alcohol use disorder. We've spoken to a bunch of national experts over the last year. And one of the things I'm often struck by in the work that we do in the Emergency Quality Network is most of the EDs that are part of this work are in rural areas, they're critical access hospitals, they're community-based. But I've got the two of you here from Harvard and Yale, literally the top of the proverbial ivory towers. And you've had a chance, though, to go and meet folks around the country. And so I want to just kick it off with sort of what surprised you the most? Like, where are those bright gems in emergency medicine?
It's great question, Arjun. So, and first of all, the one thing that struck me about the ivory towers is that it's just comprised of people that came from elsewhere. So we're all like, even though we currently reside in these,
yes,
we're just like everybody else. I promise. But I think the thing that surprised me, and it's kind of reminiscent to me about how emergency ultrasound came about, which initially in every department there was kind of like one person that was a champion for it. And they kind of saw the potential of this new technology, and they might have like convinced their radiology department to give them an old machine, and they would start to use it and start to implement it. And as time went on, it became an integral part of our practice. And I'm perceiving that a lot with substance use disorder treatment as well. I think a lot of departments have, one or a couple people that are really on the forefront of it. They're keeping up with literature. They're trying to roll out procedures and education in their department. And it gives me a lot of hope when I see that.
Yeah, I couldn't agree more. And one of my favorite things, I do love working at Yale. I do love being able to do, test new theories and ways we can reach people and link people to treatment. But it is really wonderful through E-QUAL to be able to work with community and critical access EDs, where we know most people in this care actually get get care. So it's been really, really exciting to see, a change in how people perceive it's not just their role, but also their ability to care for people with opioid use disorder and new this year, alcohol use disorder.
This is one of those things I was talking about. Like, it feels like as a specialty, we're moving faster than we have with other stuff. I say this because, in E-QUAL, we've also run a stroke collaborative, and there's this obviously broader, very public debate and discussion, nearly probably almost 20 years after the original NINDS trial about treating strokes with thrombolysis. This feels different. And you guys are in the thick of it. You're at the meetings in DC, but you're also working with a bunch of EDs around it. Why do you think that is? Like, how have we been able to mobilize faster around opioid use disorder than even stroke?
I mean, I think one of the clear things is that, in EDs all across the country, we're taking care of young people who are dying of opioid overdose. And that is something that, obviously we see people with bad outcomes from stroke, but I think this is something new that has shown up over the last decade that makes it really hard to look around and not feel like this is something that you should get involved in and something that you should provide whatever evidence-based care you're able to deliver to help prevent seeing another fatal opioid overdose.
I actually think it's been a little slower than I was hoping for. To be a little contrarian, like
you think I'm the optimist.
Well, I mean, if you think about like, we've seen this steady increase in deaths for the past 20 years. And it actually wasn't steady because starting, 2012 to 14, we started to get heroin, fentanyl, it just skyrocketed, right? So we've become comfortable with these like 80,000 people per year dying from this. And like Kate was mentioning, frequently young people, otherwise healthy, people in our community, so tragic. And but I think what's happened is that there's been this confluence of lots of things that came together. Evidence showing that we can do this efficiently and it works. Public policy changing again around like, let's get rid of the X waiver. Let's open up this treatment. Just more acceptance of this as a primary treatment in the ED, taking away some of the stigma. So I think we kind of reached a tipping point, and now that's why we're feeling it go faster. But it took a long time to get to the tipping point.
Yeah, I think that's a really good point because I do think, we started our first opioid E-QUAL initiative in 2018. It was initially focused on prescribing, as you guys know, for the first 2 years on opioid prescribing. But when we started talking about sort of are people post-overdose being prescribed naloxone or leaving naloxone, this is around 2020. So obviously a lot happening in the US healthcare system around that time. But the numbers were lower than we expected. And we've actually seen like a fairly nice increase in the prescription or provision of naloxone post overdose over the past 4 years we've been running the collaborative. The flip side is, is what Scott was alluding to. I mean, we've also seen very big increases in the provision of medications for opioid use disorder, including buprenorphine and methadone. But they were such small numbers to start with. There's still so much room for improvement. And, as you know, that's how we've been spending a lot of our time this year, is trying to support EDs that are interested.
So I love numbers. I love data. A bunch of people who listen to this podcast are really obviously interested in evidence-based medicine and getting knowledge into practice. So I'm going to put you both on the spot with a pop quiz question. You're both big-time researchers. I know you guys love the literature and you're in the thick of it. What's your favorite paper in the last year that an emergency physician out there should know about when it comes to substance use disorders?
Oh, I'm going to be totally immodest here.
That's fine. If it's your own, you could totally make it your own.
Yeah, it is. So we have a paper coming out in July. It's going to be in JAMA Open, and it's embargoed, but I'm going to just give you the punchline that if a patient has evidence of receiving MOUD, like buprenorphine or methadone, within 7 days of a discharge from the hospital or an ED visit, their hazard ratio of death, or fatal or non-fatal overdose within 6 months is 0.6. So you like this massive decrease in the risk of overdose by an intervention that we can do from the ED, like start today. So I'm sorry that I picked my own. That's really totally immodest, and that's like, I guess that's the ivory tower Harvard person. But I hope it makes a lot of impact because we had that paper several years ago that showed that about 5% of people that were discharged after surviving overdose died within a year. And I think that made a lot of impact. It just kind of woke people up to the risk of this population, and that these are people that were discharging. Most conditions where you'd say you'd be dead in a year, like a 1 in 20, we do a lot more for. So I'm hopeful.
Yeah, I mean, I think I love that, and I love you mentioning that 5% paper because it was one that helped me rethink how we reference and think about the population, especially because we're talking about young people, right? We're largely talking about much younger people. And if I told you for any other condition that you had a 5% mortality rate on discharge, those are the people that we see that have severe coronary disease and have heart attacks and then get discharged, have a 5% mortality rate in a year, right? Those are the people that have a stroke are able to survive it and make it out. And I think we have sort of wildly misclassified the fact that you got discharged from an ED as prognostically safe, and that if you got it admitted to a hospital, prognostically dangerous. And that's a false fork in the road. The reality is that there are really high risks of poor outcomes amongst certain discharge populations. This is probably the best example. And there are probably some people who remain in the hospital who, don't come near that risk of annual mortality. Kate, how about you? Favorite paper of the last year?
Oh, it's so hard. I mean, I think some of my, as Scott mentioned, some of my favorite papers are really the ones that help outline, just the fact that this is, an end stage process for what, doesn't have to be a life-threatening disease. But those aren't necessarily new papers. Um, I think one that I did not lead it, but was a co-author on. So same vibe, but is I think, these papers that come out that show what you have felt you have known, but like you actually have data to support it. So it was actually led by Robert Heimer, who's an epidemiologist at our School of Public Health. And we've spent the past like 5 years trying to do data linkage, following Massachusetts lead around to try to get a sense of what happens with folks when they are offered treatment and when they are offered, what happens with outcomes. And so just in the past year, there was a publication that came out in, let me make sure, I think it was drug and alcohol dependence. But it actually showed that folks who, and again, this is just a cohort study of people who had been engaged in opioid use disorder treatment and looking at sort of outcomes afterwards. Methadone and buprenorphine, very clearly life-saving. Abstinence-based treatment that did not involve medications, people actually had a worse mortality than those who were actually not in treatment. And so I mentioned that as, not as a rationale or reason for ED docs to say, oh, you know what, maybe I won't touch people and we'll leave them alone. But it's just because that all treatment is it's so clear that all treatment is not equivalent, and that, the role of medications in helping decrease morbidity, mortality, is just so clear, that, I think it helps highlight, the need for us to do that in the emergency department.
Part of this is probably also stigma too, right? Like you go back 20 years ago and the delays that would occur around treating hypertension or diabetes were notable, right? People would go through this whole, well, we really want to do diet and exercise or something. And it would be sort of this thing where you want to blame the patient or put the problem on them, or sort of say, well, if you could just will it away, it'll go away. But we know that these are diseases and that they have their own biochemical, pathophysiologic, genetic, everything profiles that require treatment. And so I think, to me, that's what that paper showed, right? Was that if you have a disease and there's an effective treatment for it, you should treat the disease with the effective treatment for it.
Absolutely. And there's, people make the analogy of like, well, it was initially a choice to use drugs, right? I mean, and we know that now we know that it modifies the brain. It actually is a true disease, but we don't blame someone for having the first cheeseburger, right? Like we don't put that blame on patients like we do for any other disease, like we do for substance use disorders.
You've done a bunch of qualitative work, Kate, and I know this comes up a lot as a barrier where we sort of, talk to patients who have a substance use disorder and their experience in the emergency department. How has sort of like doing all this quality improvement work and thinking about all these interventions that we do been sort of informed and changed by that?
Oh, well, so I love the question, because I think the qualitative work has really informed how I think about interacting with patients. But it also breaks my heart a little bit, because it highlights things that are such big systemic problems that are very hard for us to handle or deal with in the emergency department. So for example, my first project is a research fellow. I did qualitative interviews with people after opioid overdose. And I was like, I have all kinds of ideas about, what they need. They need medication, they need naloxone. And, while that is certainly true, when you talk to people about that, I mean, they need housing, they need jobs. These are, we think about it, helps really put a lot of this in the context of sort of Maslow's hierarchy of, and those are not necessarily things that obviously that we can fix from the emergency department, but I do think that it can shape the way that we have conversations around offering people, treatment and harm reduction around, whatever resources are available. And then the other one that was very, very clear, that actually was even harder to stomach was, and these were short interviews, was how grateful people were that somebody sat down and talked to them for 15 minutes about what they wanted after an overdose, which just so clearly highlighted to me that, this was a group of folks who don't feel like they necessarily had a voice within the healthcare system for what they wanted and they needed. And so, those are things that we've definitely tried to incorporate when working with residents and other support staff in the ED around how we, acknowledge that there's been prior stigma or stigmatizing interactions in the ED and help engage, patient-centered resources moving forward.
I whenever I hear you say that, it reminds me of this phrase we used to use in an earlier E-QUAL collaborative around imaging, which is, I call that evidence-based art. And the reason I say that is when we talk about medicine, we always say there's an art and science to medicine. And when we talk about evidence-based medicine, we're always thinking that it's about evidence-based science, meaning that I need to have a randomized trial to tell me whether to give drug A or drug B to somebody. Right? But the reality is that even the art of medicine has evidence. And it's sort of what you just described there, right? That's when an emergency physician is at their best, talking to that patient at a time when they may feel remarkably vulnerable, having that conversation, eliciting that patient's preferences, ideas, their situation. And that's all the art of medicine. It's what we many of us probably come into the specialty to do and feel. But it doesn't mean that it's void of science, right? That there's actually is a method to that as well. And I think that actually, to me, is, if we think about how you want to protect our job against artificial intelligence, it's going to be evidence-based art, right? The computer can figure out which drug to give. It can't do the other thing.
That makes sense. And I mean, I'll say, like, one of the phrases that I have found goes the longest, like, gets me the most leeway in establishing a therapeutic relationship with many of these patients is, like, I recognize that you have probably had bad interactions in the ED before and you have not always been treated well. I would like to help you get what you need today. And so I think even just this sheer, I mean, it's not just people who use drugs. I also say the same thing, to people that we're taking care of in the hallway, right? But I mean, I think it just in general, if you just acknowledge, there is a thing that is happening that is not ideal or has, been in the past, it really helps establish some trust to move forward.
Scott, tell me about how, because I'm thinking about this, like, both of you as researchers, it's easy, I got to think, for you to get jazzed about this work, this topic, and this space. But through the E-QUAL network, you've now started working with a variety of different EDs, and particularly with this project that we have support from the Ford Foundation around the Boost program. You're working with a lot of EDs that are, they're not going to have a local necessarily addiction medicine certified physician or researcher in substance use disorders. And so when you don't have somebody who is whose identity and expertise is in this space, what have you found is their what makes them want to be a champion? What's brought them to the work?
Yeah, there's a couple of things that resonate, and one of them I was reflecting on as you and Kate were just speaking, because the qualitative work from the perspective of the patient is really important, and is always paramount. But it is important to talk about the experience of physicians as well, and particularly in these times of unprecedented burnout and just focus on wellness that we should be having. So there was a project that Jessica Heil did with Rachel Haraz that I was able to be a part of this last year, where we said let's flip the script and let's do qualitative interviews of physicians working in places where they actually do this, where they have buprenorphine and they can refer them to a bridge clinic and they can follow up. And it was really amazing. It's like it completely changed the emergency physician's perspectives on this whole patient population. It gave them agency. It changed their emotions to going from, oh my gosh, another overdose patient, to where's the next one? I want to be there. I can help them. And as a result, it actually improved their quality of life too. So in one way to convince physicians, even in places that don't have a robust program yet, is that this is kind of a wellness initiative for us. I mean, you think of how defeatist we felt for so many years of watching someone in the hallway, judging them, discharging them with a piece of paper that was never going to be helpful. So that's the first way that I think is helpful. And then the second is really just sharing the evidence and showing that this works. Again, same thing. We knew for years we were using clonidine and benzos and Dancitron, and it was like just prolonging the inevitable, masking symptoms, but you can actually just treat the root of the problem and people get better and they're happy and you're happy and they live. There's very few things more compelling than that.
I love that story because it reminds me of, I was working a shift a couple weeks ago and I had a resident next to me, and there was sort of, you know, on the side of the ED where there's multiple teams, multiple attendants, multiple residents, several patients, and we call it red, meaning need to be seen and signed up for. And one of the patients' triage request was seeking treatment for OUD. And we only have a few minutes left. It's like probably a half hour before sign out. So you want to pick up the patient that you know you can see and get done. And I click on it and I take the patient. And I was like, oh, that one's easy. Let's take that. And the resident looked at me like I had 4 eyes, right? Because like, what do you mean that's easy? I go, that's of all these other ones, there was an abdominal pain, some chest pain. Like that's the easiest patient. And sure enough, we signed up for the patient. We walked over, saw that patient. We're able to quickly decide, use the pathway. I can't remember and keep anything straight. Right? Use the pathway to figure out that, okay, this patient needs treatment. I'm going to do this whole thing. And in 25 minutes, literally, we were done.
Yeah.
Right?
Well,
with all the medical decision making and everything that was needed. And I was like, that just went from being this like chief complaint people dread to being the easiest, the chip shot.
Well, and one of the most evidence-based interventions that you can do that so clearly reduces morbidity and mortality. It is, yeah, I love that you mentioned that, Scott, because we did, you know, I like in my mind, you know, at Cooper, it is always, I know it hasn't always been an amazing place, but there's just such, it seems like there's always been a lot of enthusiasm led by Rachel, which has been so exciting to see. But we were sort of pulled in to do implementation in some rural and critical access hospitals that they were not excited to see us. They did not want to do this. And so we actually got to see, we had sort of very, very high level support from the CMO, which is wonderful, but like, you know, you need to have some support from an interest from ED docs on the ground. And so we got to see over the course of, I'm not sure that I want to do this. I don't think this is my job, to sort of post interviews where people were like, this is great. I want to find that patient. This is, you know, it's helped protecting me from burnout. So, I mean, it is something that I think we've seen in lots and lots of EDs. It is really wonderful.
I want to also make sure that we get to talk a little bit about alcohol. We spent a lot of time talking about opioids, but I know in the initiative we're doing a lot more work around alcohol use disorder. And, you know, as a quality improvement, quality measurement guy, the original dogma in the QI world would say, you know, you have to be really careful about getting initiative fatigue. That one of the things that makes quality improvement more successful is when there's focus, there's a broad understanding of a singular goal, and you go after that. And that you sort of success breeds success, meaning that you build off of one success to go to the next one. The E-QUAL network's taken on engaging emergency departments and EDs in treating alcohol use disorder. And like you just said, you know, we have a lot of ways to go till we can declare success in OUD. And do you worry about this sort of dilution and initiative fatigue, or is there something special here where we can do both or do them together in a way that we really have impact?
This one's interesting, and I think this is a moment for piggybacking. There are a lot of, even though alcohol use disorder and opioid use disorder are different, there are medications for both of them. The medications for opioid use disorder are, of course, for the ED, we would use buprenorphine or methadone. There's logistical issues around them, controlled substances. Methadone needs follow-up at a special clinic. Like there's a lot of hassle around it. For AUD, we're proposing basically just 2 medications that people can use. One is naltrexone, which decreases cravings, and the other is gabapentin, which can decrease cravings and treat mild withdrawal symptoms. We're already familiar with gabapentin, right? We already use it, so that's not a big change. And naltrexone is a very benign medication. It's like pretty safe. You don't want to use it in people with end-stage liver disease, but otherwise it's okay. So I think it's a nice model to piggyback onto what we're doing from starting buprenorphine. And it just kind of slides right in. It doesn't feel like it's a much heavier lift after we've addressed buprenorphine. I don't know if Kate, if you agree with that or not.
Yeah, no, I think that's absolutely true. The one thing that I will say, and this is part of why there are a lot of reasons I love buprenorphine, but it is a medication you can give to someone and withdraw, and like 20 minutes later, they feel better. Everyone, you know, it is so clear to everyone, including the patient and anybody within sort of a, 20-foot radius, that this is a medication that works and helps people feel better. And that is not necessarily the case with naltrexone and gabapentin. And so it doesn't mean that they don't work. They definitely do. But I think that that little umph of like, it's so clear, where you have people, come back, or even before they leave from that visit, say, I feel normal. I think we're not necessarily going to get that feedback with alcohol, but, the flip side is, of course, untreated alcohol use disorder is an even bigger problem. If you look at sort of the burden in the US and deaths associated with it down the line.
But I'm glad you mentioned it, because those of us who work in the ED are such adrenaline junkies that we're like always looking for that instant gratification, right? It's like why one of my favorite procedures is the reduction of the finger dislocation. And so I think having that sort of set expectation for alcohol use disorder is important. It's good to know that you're still having impact, but you just may not see it in front of you right away. This is great. It's been wonderful having you both. Share with me one thing, which is you've been in this space for a year, and you've been talking to all these EDs in this past year around how to do a bunch of additional, actually, take that back. I'm gonna start this one again. All right. So share with me this, which is you've all been in the space for a long time. You've been working with EDs now for several years. I am sure you kind of came to this work and thought about a model by which quality improvement and EDs could get better and build out these programs that you have subsequently rethought. We're not right about everything. What has sort of surprised you and changed your tack when it comes to thinking about how to get EDs more engaged in treatment for either OUD or AUD?
So, I have one thing, which is when we sort of designed and set the Boost program, which you mentioned before is founded by 4, the idea is that we would work with EDs, a local champion at an individual ED to help provide resources, help them figure out where their follow-up places are on the ground, provide protocols. The whole idea is nobody needs to reinvent the wheel. I think that at the time, that is definitely one strategy, and that works for some EDs, but it doesn't take into account how, much of emergency medicine is staffed in this country, right? Where you actually have these like physician staffing groups that can be leveraged. If you have, a group that has, a quality person or has an education person. And so it is, I think this year has been, a time to really think about, how you can, while it's important to work one-on-one with EDs, but also think about how you can, maybe take that to a staff-wide level within a staffing organization or physician organization.
I don't know if this answers your question entirely, but I think that the key themes I've seen when we've been working with sites, there's 2 of them. There might be more, but in my mind, there's 2 key themes. One is just about the medication in general. Like starting buprenorphine is kind of scary for people, again, because there's been a lot of stigma around it. And just selling that it's just like so many other interventions we do. Like it's sure, it's got side effects, but we use medications all the time that have side effects, and we know how to deal with them. Like you might give Reglan and they have a dystonic reaction, you know how to treat it. Like that's how I'm trying to sell if there's ever a case of precipitated withdrawal. Like you just normalize it, we treat it. And the second part of it is that I think people would be surprised about the resources that are available in their community that didn't exist even a couple of years ago. Because there has been a lot of push towards shoring up our addiction capacity in the country. And I think that most physicians, myself included, like if you say you're going to start something for a couple of days and then someone else is going to pick it up and run with it, we're happy to do it. And so often it's our advice to a lot of EDs is just call the local clinic, a couple places. You're probably going to find someone that's willing to take your patients and follow up. Not 100% of the time, but a lot of times that's the case. And I think that helps sell it for places that haven't done it so far.
Do you think that, like, as you sort of look forward, emergency medicine's changing. There is, you see a lot more sort of diversity in practice. The new generation of people coming out of residency, coming into practice are going to be different, right? They're much like, many of them are coming through residency training programs where either they completed X-waiver training during it or they're coming in this new world after it. And so how much of this do you think is going to be us focusing our efforts on the generation that sort of missed it, like in your ultrasound example, versus really needing to focus on everyone?
I love that question because I think the thing that we've learned about implementing these programs is you don't necessarily need to have the most established clinician in a program do it. You just need to have somebody who is comfortable in an NAD or a practice environment to do it. And to have, the nurses and physicians see that it works. And so I don't think that you need to have the most established person in the practice build these programs, and maybe they don't. I mean, I would like for them to all learn to do it, but I don't even think that that's necessarily necessary. I think what people want is someone they can ask that knows their system and their ED, whether this is the right thing to do for a patient. And as long as, we're getting those new trainees into those EDs, I do think that even if we did hardly anything else, I do think it would get better in the next 5 years around, people who are doing this and treating OUD and AUD. But the flip side is although deaths are, finally decreasing for the first time, opioid associated deaths, it's still way too many to wait. So,
All right, last question. It's a hard one. Pull out your crystal ball, okay? And nobody's going to ever hold you to account for this. But predict something or tell me something that I'm not going to expect when it comes to treating SUD in the emergency department setting as an emergency physician.
I have one. This is Kate's work that will be published hopefully soon, but I really think that there's a lot of promise of this 7-day injectable buprenorphine. I just get the sense it's going to be a game changer. Everything I understand, and I have no conflicts related to this at all, but everything I understand is that it's got great pharmacokinetics. You can give it even without significant withdrawal, kind of ramps up slowly, like what we call a micro induction or low dose induction. And you buy the patient 7 days in which they don't have to scramble to get their prescription filled at a pharmacy. They don't have to worry about the prior authorization. They don't have to worry about the follow-up in the next 2 days. And you get them out of withdrawal. And I think that's going to be a game changer. The challenge, of course, is cost, right? So hopefully that will come down. But that's looking at the crystal ball. I think that's going to be a game changer for us.
I like it. It's a good one. Kate, any predictions?
No, that is a great one. So the other thing that there's also very little precipitated withdrawal that we saw with that, even in folks with the callus of 4 or more. I think it's not really a prediction, but I will tell you that this is, I think, one of the reasons it is so important to have emergency physicians on the front line with these discussions around policy for treatment is, I think the drug supply is continuing to change and it is going to continue to change. And, the best that we can ever do is treat the patient that's in front of us. So, a lot of xylazine is certainly something that's come up a lot. I do think that this is going to continue to change and we are going to be the ones that are seeing it. And it is, I think we just need to stick with the tools that we know, which is supporting patients, getting, access to medications that we know work, providing naloxone, providing support, and doing it in a non-stigmatizing way. So it is not new, but it is like things are going to continue to change in our space. And I think we need to do the things that we know that work.
All right, I'll do my last one. My last one is going to be that I think at some point that given the size of the crisis and the inadequacies of capacity that we have in our traditional healthcare system, meaning like doctors and clinics and EDs and hospitals, that we will need some wildly disruptive thing if we really want to get treatment into every patient's hands that needs it. And my prediction is going to be that that's probably going to be that we will finally develop some sort of over-the-counter version of bup or naltrexone in these cases, and that will be a way in which you bypass the healthcare system potentially, or do it maybe through a little pharmacy facilitated access, but like the Sudafed behind this counter. But we'll figure out a way to basically get direct to patient. Otherwise, I feel like our system is so lacking in capacity and so broken, we just can't get to the thousands of people, millions of people out there that we need to get to. So hopefully on those positive predictions, we'll do this again in a year and we'll take stock of where the E-QUAL initiative is, and we'll have more wins to discuss, and we'll have made more progress around this problem. Thank you both for joining today, and most importantly, thank you both for all the work you're doing for the specialty and leading in this space and really helping so many patients around the country.
Thank you. We couldn't
having
do
us.
the work that you did to put this all together, and your guidance and mentorship, and just really appreciate it, Arjun.
Yeah.
Thanks, guys.